Great, thank you. My name's Chris Kobolewski. I'm a consultant neurologist in Manchester and chair of the scientific advisory panel for the MSA Trust. And I think it's I'm really glad to hear that we've got some exciting talks uh, to look at this afternoon, with particular reference to the role of imaging in MSA. And I think imaging's something that plays a key role in MSA diagnosis. And I think our colleagues who are going to talk here are going to talk a bit about how the role of imaging might be kind of expanded in MSA. So just to kind of a bit to give a bit of background, imaging studies of the brain, like for example, MR brain imaging studies, are often done to kind of support the diagnosis of MSA, and that's become increasingly important as the current MSA diagnostic criteria that were revised in 2022 by the Movement Disorder Society now include imaging as a supportive feature, which allows us to raise the level of diagnostic certainty. So really highlighting the importance of imaging. And indeed, studies have shown that the presence of imaging does improve the kind of specificity of an MSA diagnosis, which is particularly important when we don't have other clear tests to confirm that diagnosis. We also have imaging of a number of other modalities that we can do. So, for example, imaging of function such as the dopamine system in the brain, inflammation within the brain, and indeed we can use MR to look at other aspects of brain brain function as opposed to just structural changes that we see to help with the diagnosis, as I think Professor Hoggard's going to talk about in his talk. But I think so. I think what I'd like to do is introduce our first speaker. So this is Professor Nicola Pavesi, who's a neurologist and a professor of neurology in Newcastle. And Professor Pavesi has got extensive experience of all manner of imaging modalities, really, in a number of neurodegenerative conditions, including MSA. So he's been involved in imaging studies of inflammatory traces in these conditions, of MR imaging, and he's going to present a study which is really looking at how we may help to improve the early diagnostic accuracy using multimodal imaging in patients with Parkinsonian disorders, including MSA, and also REM sleep behavior disorder. So thanks, Nicola, for coming today. I'll hand over to you. I think we'll have your talk, and then perhaps we'll have a few questions after that, and then the second talk, and then we'll maybe have a kind of wrap-up session at the end, if that's okay. Thanks very much.
Thank you, Chris. Just let me open my presentation. Okay, thank you so much, Chris, for the very kind introduction, and thank you for the invitation to give this talk on some of the results of my research, which has partially been also funded by the Multiple System Atrophy Trust, so I'm very grateful for it. I'm going to talk here, but I also want to acknowledge my colleague, Dr. Jacopo Pasquini, who has been involved in the research that I'm going to present, and also is the first author of the papers that we have published. So the first thing that I would like to start with is that, unfortunately, when we talk about Parkinsonism, we talk about conditions that have a lot of similar symptoms, and there is a significant overlap, particularly in the early stages of the disease. Very often, all patients present with the Parkinsonism. That is a combination of tremor, rigidity, bradykinesia. And only later on, they start developing all the symptoms that enable us to differentiate one condition from the others. And this is just an overlap that we can see in Parkinson, multiple system atrophy, dementia with Lewy body, and progressive supranuclear palsy. But we also know, specifically talking about MSA, that the problem, particularly when there is a Parkinsonian component, as you can see in this diagram, especially we know that disease can start years before, or even a decade before we make the diagnosis of the first symptoms. But you can see that in these very early stages, the symptoms tend to be very similar. Even if in MSA, there can be some non-motor symptoms that can occur very often, but very often these are non-specific. They can be also found in the general population, so they not really help us to differentiate. It's only later on, after 5-6 years, that we start noticing the most significant differences between the two conditions. So we need something that help the diagnosis here at this level in the early stages of the disease. Can neuroimaging help with this? Chris has already told you that yes, neuroimaging has given us a lot of information about these conditions, and I will try to summarize before talking on my results of why we do need more compared to what we have at the moment. I'm sure you're all familiar with the DAT scan. The DAT scan is that modality, imaging modality, that enables us to look at the dopaminergic system in the brain. This is a normal scan. You can see that this area here is the striatum, is the part of the brain that is involved in movements, where the majority of the dopamine terminals are. And you can see that the dye that has been injected in this patient accumulate in this very nice central part of the brain, and you have this shape of a coma. These structures, if you are interested, are the caudate here and the putamen. That's what it looks like in a normal subject, but also is similar to this in people who have essential tremor, in people who have a vascular tremor, and also in people who have been taking medications who are blocking the dopamine receptors, and therefore they have symptoms that resemble those of Parkinson's. In abnormal, people who have a reduced dopaminergic function, the DAT scan looks like this. You can see that all the posterior part, which I told you is called putamen, has disappeared. And that indicates that there has been a loss of terminals, a loss of the projection of the cells in this region. Yeah, and this is also what we see in people with Parkinson's, but it's also what we see in people with multiple system atrophy and in other conditions like dementia with Lewy body and progressive supranuclear palsy. So while that scan is able to differentiate well from normal or essential tremor, unfortunately, it does not give us any information on which one of these conditions are we dealing with. And I can give you an example of this. These are 3 different patients that I've seen in my own clinic. And you can see that compared to the normal here at the top, all 3 of them have a reduction of the uptake of the tracer, which, as I've mentioned, is similar. It's the posterior part that is disappeared. So all of these are compatible with the reduction of dopaminergic axon in the brain. And all these gentlemen are the diagnosis of, actually one was a lady, are the diagnosis of Parkinson, because the symptoms were including Parkinsonism. But after a few years of follow-up, the diagnosis changed. You can see that only the first patient had Parkinson's. The other 2 people had progressive supranuclear palsy and multiple system atrophy. So although very useful, as you can see, this test does not help us to discriminate in early phases between these 3 conditions. MRI can be useful as well. In Parkinson is generally normal, but in other conditions, like for example in MSA, we can see some typical features. Here you can see this part of the brain is the pons, and you can see that there is this clear cross in here, that the signal is less prominent and reminds the hot cross band. And this is related to the atrophy of the fibers that are present at this level. Another thing that we can see in MSA on an MRI is that these are now sagittal images. So as you can see, that are you can see the silhouette of the person, and you can see that one of the striking things is the atrophy of the pons, the atrophy of the cerebella, and also there is this ventricle here is dilated, suggesting that there is some atrophy in these specific areas. In PSP, we also have some characteristic features, but this time, as you can see in PSP, is not the pons that is involved, it's more up, is the midbrain, and gives this characteristic typic form of a bird, which is quite typical. But unfortunately, all these features are late features. We don't generally see at the very early stage of the disease. They tend to occur several years after the onset of the disease. So we need something that is more useful in early phases. Positron emission tomography can be helpful. With positron emission tomography PET, we can look how the brain is using the glucose, the sugar that is used for to produce energy in the brain. And you can see that the kind of metabolic network that you see in the brain with someone with Parkinson is different from what you see in patient with MSA. In Parkinson, we have these red areas here that are increased, and this is the thalamus, but we also have a reduction in the motor cortex and a premotor cortex in the occipital areas. While in MSA, we generally have a reduction of glucose metabolism, so reduction consumption of glucose in the putamen and also in the cerebellum. So that could be useful, but the problem with PET is very expensive, is not available everywhere. And the other thing that is important is that this methodology is not standardized among centers. So we really need something that is simple, something that we can use and not too expensive. And that is where we decided to look at specific types of MRIs that could help us to try to, first of all, to differentiate Parkinson from multiple system atrophy and the controls, and also to see if we can get more information about how the disease is affecting the brain. So we would like to, what we wanted to do is to use this more advanced MRI techniques using also a PET with FDG, so with the glucose consumption. And the first study that we did involved 11 participants with multiple system atrophy, 18 participants with Parkinson's, and 18 healthy control. We used a number of clinical scales like the UMSARS. We wanted to check the cognition with the Montreal Cognitive Assessment and also anxiety and depression. These are very validated scales. Possibly you might be familiar with those. It's with the ones where we check the degree of the tremor, the slowness of movements, eye movements. So just to give a score of the severity of the disease. And then we performed the PET scan with FDG. And then we used a new technique for MRI for the neuromelanin and the NODI, which stands for Neurite Orientation, Dispersion, and Density Imaging, which is a measure of the macrostructure of the brain, of these small terminals, all these projections that are coming out from the cells and projected to different parts of the brain. And these are our target. These are the regions that we wanted to look at. The substantia nigra, which is here high in this part of the brain that is called midbrain, and projected to the frontal cortex, but also to the striatum, so that area that you see in the DAT scan. And then we were interested in the locus ceruleus. That is another crucial part of the brain. It's a bit lower, as you can see here, and produces another chemical which is called noradrenaline that has a lot of other function, including sleep problems, cognition, mood, and so on. So these were our targets. And why could we use MRI for this with the neuromelanin? Because these two structures have a specific pigment which is called neuromelanin that can be recognized on an MRI. This is, again, is the midbrain. We are here at this level of the substantia nigra. You see, substantia nigra means a dark substance, and it's called that because you can see that there is this dark signal in here. And this is caused by a pigment called neuromelanin that is contained in the dopaminergic neurons. See, this is what it looks like. This is a postmortem. So this is a sample, a postmortem sample, and you can see that is a normal with a lot of substantia of pigment. In Parkinson's, where there has been a loss of cells, of course, there are less pigments, so that seems to be clear, is pale. So that is what we wanted to look with MRI, if we can detect this difference, that is quite visible post-mortem. And the same thing is the locus coeruleus. As I mentioned, locus coeruleus is noradrenaline, but the cells of the locus coeruleus also contain the neuromelanin, therefore they look dark. So I'll show you what we can see then in the imaging. So this is the same structure now on an MRI, so in a living person. And you can see that in a healthy subject, there is a lot of bright signal, which is corresponding to the neuromelanin. And you can see that is reduced in patient with Parkinson's. This is just one subject, and is reduced in a patient with MSA. So what we can do, we can have a method to measure how bright this region, so to quantify this region. What we do, we divided this region in anterior part and in the posterior part, and we compare what measuring here the signal, the intensity of the signal, with the reference region, which is this part here that you see is not dark. So with this relationship, with this ratio, we can measure how bright these parts are. And the same thing we can do for the, and that's what is what you can see once you have done the contrast. You can see that, so this is the difference, and you can see that is what looks like in this patient with healthy subject, and that, as you can see, is reduced in patient with Parkinson and in patient with MSA. The same thing is for the locus coeruleus here. Here we divided, locus coeruleus is quite long, so we divided a rostral part, a middle part, and then a rostral part. And that is NODI. NODI, that is the target that we are interested. So again, I'll show you, we are looking at the putamen here. We look at the globus pallidus, that is another structure that is important for movement. And we also look at some cerebellar areas. And these are our results. In Substantia nigra did not differentiate people from with Parkinson from people with multiple system atrophy. And there was no, but the most significant difference was related to the locus coeruleus neuromelanin, particularly in the middle part and in the caudal part. Especially the caudal part was significant in patients with MSA compared to the control, but not in patients with Parkinson, suggesting that MSA patients can have more significant degeneration, cellular loss of neuromelanin in compared to the Parkinson and the healthy control. And we also found that this reduction of neuromelanin was correlating with changes in glucose metabolism in the frontal cortex, suggesting that the loss of locus coeruleus cause reduction of axons and therefore of metabolism in the frontal cortex, and was also correlated with the cognitive function. So the lower was the neuromelanin and in the locus coeruleus, in the rostral part, the more and the FDG, the reduction of glucose metabolism, worse were the scores of these patients on the cognitive tests. NODI is also more interesting. These are unpublished data. We haven't published that yet, but you can see so that you have in blue the healthy controls, in red the Parkinson's, and in green the MSA, and you can see that the MSA in different areas of the brain are able to differentiate Parkinson from MSA. So something that would indicate, of course, this is a very small number of patients, but it could indicate that there is something that in this early phase, because these were patients that had less than 3 years of disease, we can find some differences in these very early stages. And this is still NODI in other different areas. This is the neurite density, so that the microstructural abnormality in the density of these terminals. And again, you can see that the MSA and the PD patients are well behave very differently. So this is the conclusion of the first part of my talk, suggesting that locus coeruleus and neuromelanin could potentially be useful to differentiate, particularly the rostral part could be useful in differentiating Parkinson from MSA in the early stages, but the most promising seems to be NODI. But again, as I've already mentioned, this needs to be assessed in a larger cohort of patients. Then the other part that we were interested is isolated REM sleep behavior disorder. So I'm not sure if you know what what REM sleep behavior disorder is. So when we sleep, particularly in the phase when we dream, the body is completely paralyzed. The only part of the body that is moving are the eyes. So REM means rapid eye movement. So that is the only part of the body that is supposed to move. But in people who have REM sleep behavior disorder, the body is not paralyzed. So there is this sort of disassociation with the body and the sleep. And people, as I mentioned, this is the phase when people are dreaming. Therefore, people tend to act what they are dreaming. So if they are dreaming of being on a boxing match, they start punching and kicking. Not it's not allowed, but they tend to do the worst thing. And we now know that REM sleep behavior disorder is a strong predictor of Parkinson's, dementia with Lewy body, but also in some cases of multiple system atrophy, because it seems that is the pathology of these conditions, the aggregation of alpha-synuclein that is typical of these disorders, that has already affected the centers that are regulated sleep. So that could be the first symptoms of the disease before the classical start of the motor symptoms. So this is a very important population because if we manage, particularly if we start having medications that can slow down the progression of the disease, if we manage to identify these patients who already have some indication that some pathology is going on, then we can start this treatment very early before the decline of clinical function. So we wanted to use the same techniques that I've told before, the neuromelanin and the NODI in this participant with REM sleep behavior disorder to see if we could find the same kind of abnormalities in these patients. We had 14 patients with REM sleep behavior disorder, 18 patients with Parkinson and 18 healthy control. Parkinson and healthy control were the same subjects that we had, the same participant for the older study. We did the same kind of assessment completely at all. And what we noticed that, again, there were some interesting results that people with RBD had reduction compared to the healthy control that were similar to the one that were in people with Parkinson's. And we also found that there was a significant correlation between substantia nigra neuromelanin and the indication and the measures of NODI, suggesting that the less neuromelanin in the substantia nigra in this patient, the more abnormalities you can find in the macrostructures of the brain. This only was true if we were combining the RBD and the PD patients, considering them as they were part of a singular spectrum, indicating that we probably need larger cohorts of patients. So this is my final conclusion for this second study. People with isolated REM sleep behavior disorder have a significant neuromelanin loss in both in the substantia nigra and in the locus coeruleus, and this can occur before this patient had any changes in the DAT scan that was also performed in these patients. And the other thing that we noticed is that there was a very significant correlation between the neuromelanin in the substantia nigra and NODI measures, suggesting again that this is a technique that we need it's easy to use, and we need to investigate further to see if can provide early markers of these conditions, which would be fantastic. And just want to acknowledge the multiple system atrophy that provided us the grant to do these 2 studies. And of course, all the study participants that very generously give their time to be part of this research, making science to progress. Thank you.
Great. Thank you very much, Nicola. That was very interesting. So I think we've got time for a few questions now. Maybe we'll have a few questions now, and then we'll have a more kind of general Q&A session at the end. But if anyone has any burning questions now, I don't know if maybe it's easiest if you raise your hand if possible on the Zoom, and we can find who you are. Or perhaps while we're waiting to see if anyone has any questions. Oh, I think we have a hand raised there. Is it Mandy? Sorry, I can't see everybody on the screen. You see, so it may be easier just to use the hand raise icon, but I can see your video, so I can see you have your hand up. So do you want to just unmute yourself and just go ahead?
Okay.
There we go. Yeah.
Hello.
Hi, Mandy.
Right. I was diagnosed with MSA 2 years ago, with potentially 4 years prior to that of symptoms. Unfortunately, some of the symptoms I definitely know started 10 years ago. But being as so many MSA symptoms are disregarded, they're counted as something else or age related, so it's all missed, and it's only when something significant happens, like I kept having falls, that my GP knew something about MSA and sent me to a neurologist, and there, and it all snowballed from there. So unless you actually suspect MSA, why would you put somebody through all these tests when they're so expensive?
The reason for that is because now we know. Are you okay, Mandy? Can I talk? Okay.
Yeah, please carry on. It's just my chronic chest condition.
Yes. So the reason for that is because we don't do these tests when the symptoms are very vague. We call this enriched population. So we try to better understand people who have clusters of these symptoms that enable us to see that something is going on. And REM sleep behavior disorder is one of the strong risk factor for Parkinson, because we know that there have been longitudinal studies that have shown that if someone has REM sleep behavior disorder, over the next 5-10 years, the chance that the person develop Parkinsonism is up to 90%. And we are able to detect from the lumbar spine, we can analyze the spinal fluid, and we know that people already have alpha-synuclein. So we are not doing these tests to everyone. We only do these tests to people who have several symptoms that clustered together tell us that that person has already an ongoing pathology, not the classical motor symptoms that we generally help us to make the diagnosis of Parkinson's, but other symptoms that are in the prodromal phase. Why we want to do that? For 2 reasons. One is that maybe we can start more, if we identify patient very early, we can start, for example, if we know that someone has MSA compared to Parkinson, we can start with more appropriate management, more intense physiotherapy, rehabilitation for falls, as you will say, prevention for falls. So we improve the quality of life. But then at the moment, there are new medications that are coming out, particularly these medications that are targeting the alpha-synuclein, though this abnormal protein. So if we identify this population that is already has changes in their brain, we can probably slow down and halt the disease itself. Apart from the alpha-synuclein, we also know that the, neuroinflammation plays a role in this condition. So if we get a very early stage, we have more chance of success, because when we start this protective treatment, when the person already has very significant symptoms, it might be too late, because we might have already lost a large number of neurons. While if we start early, we still have a lot of neurons to protect. Does it make sense?
It does. My beef is that I've got all these symptoms. There's definitely cerebellar atrophy. The DAT scan showed changes, yet I've still not been selected to go on any medication to slow down the progress.
Because Mandy, we don't have any at the moment, but there are clinical trials, and
I've said that I would be willing to go on a clinical trial.
I think Mandy, I think as you'll probably appreciate, it's difficult for us to talk about individual people's cases, because we obviously don't really know the full details of your case and so on. So I think what Professor Pafesi is saying is that if we can identify people at an earlier stage, then they may be potentially more open to interventions that may have a better chance of success. Obviously, we can't really speak to why you what's been going on in your case, but I do appreciate it's very difficult, to live with the uncertainty of the diagnostic process, and then obviously in a situation where the treatments to actually change the progression are not really there as things stand. So does anyone else have any other questions at this stage for Professor Pavesi? I think if there's nobody else, I can't see any hands raised here. So probably what we'll go on and do.
I got mine raised.
All right. Sorry, I can't see everyone's video. You see, so it's probably easiest if you raise your hand using the Zoom function if possible. But sorry. So I don't know if you. Yeah. Do you want to go ahead? Yeah.
Hi, my name is Joe Minuti. I'm actually here with my wife, because she was diagnosed with MSA. August 22 by Dr. Gratwick at St. George's in London. We've recently moved up north into this area, and the GP doesn't seem to sort of know, how to treat or even carry on with any medication that my wife might have. We've got a referral to Professor Pavesi at the moment, but we haven't heard anything back. So we're really looking at, forward to actually meeting you at some point. I'm sure you're probably very busy up there, but
when was the referral letter to?
Only about 2 weeks ago.
Okay.
Because we moved up here in September, but my wife hasn't been able to see a neurologist for about 18 months now, because the one she was seeing in Kingston Hospital, she went on maternity leave, then came back, and just gone from one place to the other and just carried on.
I mean, send me an email and I will try to sort it out. I'm very sorry about that.
That's okay. It's not your fault, Professor.
Yeah.
I think what I would suggest is probably also that hopefully you can be linked in with an MSA Trust nurse who covers the North East region, and the MSA Trust nurse, I don't know who exactly it will be, but that person will be able to kind of point you in and hopefully have the appropriate contacts to sort this out. Because I appreciate
in contact with the nurse, and she's in fact gave us the name of Professor Pavesi, but she cannot do anything until the GP does something.
Okay, I think hopefully this is something that can be sorted, out with the webinar today, you know, because we're sort of
Okay.
mainly trying to focus on the research questions, but and it's hard for us to kind of go through individual cases and so on, as
Of
I've
course,
said, but
yeah,
hopefully
yeah,
this can
I
be sorted out,
understand.
I would think. So I think we
Okay.
have a hand raised by Steve Hughes. Is that right? Do you want to go ahead?
Yes, very quick question, I hope. Is sleepwalking regarded in the same way as REM body disorder as an early indicator, or is that not the same thing at all?
No, generally not. This is more something, is a different kind of parasomnia. So it is mostly people who are acting in their dreams. With sleepwalking, no, I wouldn't say there is any strong evidence.
Right, thank you.
Okay, great. Well, thank you, Nicola. So I think what we're going to do is we're going to move on to the second talk today, which is by Professor Nigel Hoggard, who's from the University of Sheffield. I think we have Professor Hoggard on the call. Yeah, here we are. Here he is. So Professor Hoggard's a professor of neuroradiology, so is literally a specialist in brain imaging who works in Sheffield, and he works very closely with the ataxia service there, who have a large MSA service in Sheffield. And so Professor Hoggard is going to talk to us about physiological imaging for improving for faster and more effective clinical trials in MSA. So Professor Hoggard, I'll hand over to you. Thank you.
Thank you very much for the invitation. I'm hoping that you're seeing my screen now. Is that right?
Yeah.
Yes, that's fine. Yeah.
Brilliant. Okay, fine. So what I'm really going to do is give you a bit of an update of where we're at. We're not quite as advanced with some of our studies as Newcastle are, but we'll show you where we are. So I work with Marios Hadjivasiliou, and we have a lot of patients with MSA, and a lot of those have the ataxic form of the illness. But equally, we have plenty of patients with Parkinsonian features as well. So let's get stuck into what we've been up to. I would do if it's okay, fine, right. So we're currently looking at retrospective analysis of 55 patients with MSA, and that's one of the studies we're ongoing. Then we've got another study which is looking at the phosphorus imaging, which is what we'll come back to in terms of the physiological imaging of MSA. And the idea is that I'm interested in trying to use imaging instead of looking at the anatomy, whether something's getting well, obviously in most neurodegenerative diseases, things getting smaller, but looking at things that can be measured that go up or go down over a period of weeks or months to see if we get a response to treatment. And that was sparked by our interest, which was began quite early on in our journey with ataxia, with this observation that you get these. This is biochemistry of the brain, and this is something called AA, and that's a biochemical which is made by happy, healthy neurons. And you can see that actually it should be right high above these other peaks here. It should be the biggest peak on the spectrum there, and it's not. And it's quite a profound drop in this biochemical NAA. And it also, we've demonstrated that it correlates with the severity of disease. So what we also noticed quite early on was that actually we were noticing these changes well before the kind of changes on anatomy that people use for the diagnosis of this condition, something called the hot cross bun sign in the ataxic form of the disease, which is signal changes in the brainstem. And a lot of patients in most centres will probably not get diagnosed with MSA until those sort of changes emerge, whereas in Sheffield, we are diagnosed people well before that. And that goes back to something that from the first talk that we just heard about, this idea that it's really important to get in there early to try and maximise the amount of brain tissue you can save by your intervention. And so that's our motivation for the research that we do on all of it, on imaging. And this is just another observation that we noticed, that actually there's this kind of quite a specific pattern that we see in these patients. So we get demonstrate here are changes. This is called the vermis. This is the bit that controls balance in terms of standing, sitting, kind of trunk of the body. And that tends to always arise before we see any changes in the hemispheres. And the hemispheres are areas that control speech and more a limb and other areas of cerebellar activity. And you can see that a year later, things have significantly changed. So if you look, the NA here is normal, and then a year later, it's started to drop, following on from the same drop that we've already demonstrated in the Burma. So you see quite a rapid fall off in spectroscopy, and that's before really any kind of change in the anatomy has arisen. And this is just something just shown in graphical form. So don't need to worry about these numbers too much, but this is just the ratio of these two peaks. This is called creatine, and that tends to stay the same in people. And this is the NAA, this healthy, happy neurons kind of marker. And we see that that's dropped quite dramatically over a period of a year. And so it means, and the Hockrus-Bunstein will probably be emerging sometime around 1 or 2 years at this point, okay? So we've got that extra time to get in a new intervention into the patient because we've got a firmer diagnosis. And this is just a study we did, and we're expanding currently. So we had these series of patients with different severity of the ataxic form of illness and compared it to different groups. And we demonstrated that actually these were the kind of ranges. This is the ratio I was talking about, that was on the graph. And you can see that it's very, very low here because this should be about 1.0. In healthy people, this is about 1.0. You can see that this is actually a very profound drop. And we can see that also in the hemisphere, which tends to be affected later, as I say, again, you tend to get these very profound drops. And then as we come further on, you see that with moderate changes, we get slightly, so this is our severe group, 0.58. This is our moderate group, 0.63. And the NAA in the hemisphere was down here at 5.7. And this is 0.99, which is almost normal. And then we've got the mild end of the spectrum, very early people with disease. And again, we've demonstrated here that actually we've got a good response in terms of our spectroscopy too, which correlates with the severity of illness. We also looked at comparing people with a final diagnosis of MSAC to different groups, and we looked at people by trying to match them for age and for other illnesses that are quite similar to our cohort. And what we demonstrated was that actually there's a significant reduction in the NAA creatine levels in the MSA when compared to those of other similar illnesses which present a similar kind of age group, which often get confused. Okay, and that would slow down the diagnosis. Okay, that was that's our initial work that we've been doing in the past, and that we're expanding currently. This is more recent work. So the physiological imaging part of this is that we're interested in something called phosphorus. Now, the energy molecules in the body, in any cell, in fact, are related to a chemical called phosphorus. And phosphorus is attached in different ways to different molecules. And it's when you break those bonds of the phosphorus to the molecule that you release the energy. And that's what drives all the enzymes, all the cellular processes. This is absolutely a fundamental part of how mitochondria, how the power packs of the cell work, how cells in general work. And so it's a really fundamental thing we're looking at here. And you can measure that as I say, a bit like the biochemistry that we looked at in terms of the happy, healthy neurons. You can tune your scanner, your MR scanner, to pick out these phosphorus molecules, okay? And these are very, like I say, central to the pathophysiology of all neurodegenerative diseases, of which MSA is one. And our aim is, there's quite a lot of interest in this as an area, but there's not much out there in terms of how accurate. So what you need to know is, if you're going to use a test in a trial, you need to know that it's the same on a Tuesday afternoon as a Friday morning, as a whatever. And you need to look at that repeatability. Are you measuring the same thing on each occasion? Or do you have to do things in a very particular way to make sure you get reproducible measurements? So it may be that you can't drink any coffee before you have the scan. It may be that you can't have any alcohol the day before or whatever. There'll be various things that we maybe ask patients to do before they have one of these scans to make it as accurate and repeatable every time. So this is something that we've been looking at, and it needs special equipment in terms of the actual coil. Anybody who's had an MR scan will know that of the brain, will know that you put your head in something called a coil, and that for this purposes has to be tuned to pick up the phosphorus. And this is now, because of the work done in Sheffield and in Italy and a couple of centres in America, has been taken up by the companies. And this is a commercially made coil for the MR scan. And that's quite a big step forward in the field, that everyone's using these commercially made rather than making their own versions of them. And so the field is moving forward quite rapidly. And we've got this study which is ongoing. We've got 18 volunteers in it at the moment, and we've got two different distinct age groups. We've got 20 to 40, and we've got 50 to 60 to look at the differences in age. And we've got another cohort that we're also recruiting into now, who are substantially older than that, to see how much the trends that we see between these two groups are extended into the more elderly population. And you don't need to go on. I don't need to go into detail about how we actually do the mathematics of the analysis, but this is all now open source computer programs, so they're widely used, is what I'm trying to say. And these are the results that we get. So I think there's a lot of information on these, and I'll boil it down to two really simple points that I want you to take home with. If you look at these graphs and you look at age, you'll see there's a downward trend, okay? And these are in healthy people. So if we're going to use this in any trials, we need to know that actually this is what's normal for this age group, okay? And the other thing to say is actually when it comes to this very important thing called phosphocreatine, which is one of the main energy repositories for the brain, it's one of the main molecules that the brain stores energy in, is actually quite different between men and women. And it's not really been demonstrated before that there's such a substantial difference. So we're doing some nice work here, some important work, which is sort of groundwork for doing some work in patients with MSA, but we wanted to get the basics right first. Okay, so we're talking about physiological imaging. This is an image which you might recognize from the previous talk. This is a PET scan. This is looking at the use of a sugar molecule, FDG, in the brain. It gets taken up, and glucose is the main molecule that the brain cells use for basic fuel. And you can see that in these are the two conditions that get mixed up in the ataxic form of MSA, and this is aggressive autoimmune disease, and this is MSA, and they can look clinically very, very similar, and it's not at all clear perhaps on clinical examination which one you're looking at. And in terms of the actual clinical trajectory of the illness, both are very similar. And so what we see here is that actually in the MSA, there's a very distinct difference between that and between people with this other form of ataxia called autoimmune ataxia early in the disease, because they have actually increased activity in the cerebellum, whereas MSA. So we can use this. This could be useful, but as alluded to in the previous talk, PET imaging is quite expensive. However, we're pressing ahead because we want to look at that in relation to other things. So we've just finished, literally, we've got one patient who's waiting to be scanned with MSA, and we are not just looking at the PET imaging, we're also looking at some other changes on the study, which is we're also doing NODI imaging of the actual brain tissue. Again, looking at this measures the very, very fine structure of the brain tissue and changes in that. And also we're looking at something called magnetization transfer imaging, which is another method for looking at something called myelin, which is kind of like insulation material, and it's formed by these cells called oligodendrocytes. And oligodendrocytes are really important, because they have a lot of jobs, but one of them is making myelin, but also they're present all over the brain. And I think there's a lot of interest in this because there's a whole new group of drugs coming down the line which potentially could target them, and that they may be of some use in MSA in the future. So we're doing these studies, and I haven't got any data to present to you yet because we're still early days. We're only just finishing off the actual acquisition of the data, but we're quite excited by what we're seeing at the moment. So, like I say, we're just finishing off the recruitment for the autoimmune ataxic patients who are kind of rarer than MSA, harder to get hold of. But we've just recruited our final patient who's not been imaged yet with MSA in that study. And then we go on to the final bit, which is which we're due to start next year, and that will be looking at patients with MSA with phosphorus, because we're expecting, like other aggressive neurodegenerative diseases, to see very profound changes in the spectroscopy of the phosphorus, and we're expecting to see that in MSA, and we're going to be recruiting patients in that over the next year. And so when we get some results, we'll come back to you and we'll share those with you. But I think we should have some results by the end of next year. But thank you. I just want to thank all my people who've helped collaborate to do the work to date. I'd like to thank you for your attention and for your support with the research. And for anybody who happened to participate in any of our studies with MSA, thank you for that too.
Great. Thanks very much, Professor Hoggard. That was again, very interesting talk about some novel ways of imaging brain function. So I think there are a few questions in the chat here, which we can perhaps go through a bit. And if anyone else wants to say anything, again, we have some time for questions. Perhaps I'll just start to perhaps field a few of these initially, and we can put them out to more general discussion as well. So I think Jackie has put a couple of questions here. One is that because MSA is so rare, is it really likely pharmaceutical companies will produce a drug? Well, actually, there are a number of pharmaceutical companies which have already produced potential drugs for trials, and those are ongoing. We're doing one of those in Salford currently, and I think we're hopeful, obviously, for the results of those trials. But I think if it is found to work, it is likely to be something that hopefully they will pursue, because they I don't think would work on it if they weren't planning to pursue it further. But I agree, it's a difficult one because of the rarity of MSA and the difficulty of finding people for those trials.
Can I just add to that? Actually, I think there's also another approach which I think that we from the research community need to push, because there are lots of drugs out there that are already in use and could be repurposed. And I think that's something that we need to pay attention to, because there's a lot of work going on in that area in MS. And I think there are parallels with MSA that we could take from that. And I think the drug companies will be less interested in that because there won't be the same amount of profit involved for them, but they might still be of value. And so I think we need to also explore that area too.
Yeah, no, I agree with that. There is some background history of drugs being repurposed in MSA, although that hasn't yet come to anything. Obviously, there was the exenatide MSA trial, which reported earlier this year, which hasn't been definitive in terms of its answers, but certainly, I agree, that's a very valid approach. I think Viorica, you have your hand up if you want to come in there.
Yeah, I want to just quickly add that one way to deal with the small numbers is to be as specific as we can when we deal with the drug trials, and that's where areas like imaging, which can tell us that this is as much as we can, that this is MSA condition and that this marker is very sensitive to change. For example, if the drug works, we expect this change. If the drug doesn't work, we expect that change. So once we have something that helps us be certain with the diagnosis, or something that helps us to measure these changes very accurately, then we can allow to have less number of patients in the trial. And I think that's why all this stuff is very, very important.
Yeah, I totally agree with that. Yeah, I think that's right. Yeah. So I think things like, but I think both approaches, both of the approaches that we've heard today potentially could feed into that, couldn't they? And I think if we could find, because I think the other problem is that the in clinical trials, the kind of gold standard way of looking at things currently is obviously looking at clinical measures like the UMSARS. That's very variable. It can vary from morning to evening or day to day according to who's checking it. Whereas these imaging findings, provided they've been validated and they're shown to be kind of stable, they hopefully aren't going to change too much from day to day or time to time, etc. So, and that's a key point, isn't it? Having some other measures to look at for sure.
And also, I think it's important that all the things you've heard today are things that could be implemented relatively straightforwardly on standard NHS equipment.
Yeah. So we have a question from Victoria saying, if I take creatine, would that help? I think we're probably not in a position to sort of give out advice about individual treatments. It might be useful, actually, Professor Hoggard, to just explain, perhaps, because from my take on it, I was thinking perhaps the phosphocreatine measurement is probably more useful to understand the process that's going on in MSA and potentially to track changes, as Viorica was suggesting in clinical trials. But I don't know if you've got any other, not to do with whether people should take it or not, but how we see that, how we put that in context of the kind of overall picture.
Okay, so I think you're absolutely right to be cautious about what supplementation may or may not do. There's an awful lot of people out there doing it already in every gym up and down the country. And there's not much evidence, actually, that it makes there's a little bit of evidence that it might make some difference in terms of getting into the brain at all. But in terms of the actual illnesses, there's no evidence whatsoever for any of that. And all we're really doing is using it because it's the main energy store of the brain. It's going to be relatively reproducibly measured, because it's in a good concentration for us to measure, and it reflects the actual metabolic activity, the actual power packs of the cell. They're what drive its production. And so we've noticed it already. We've already published previously that it's abnormal in say, for example, Parkinson's. So we're not claiming this is specific to this illness. What we need to do is therefore have the work that's going on in Newcastle and get very firm diagnosis at the outset of the illness, early diagnosis that's firm, and then you use these other biomarkers to follow what is happening in the patient once you've established the diagnosis. We're not saying that what we're doing here with the phosphorus imaging is going to help with diagnosis. It's not. It's about looking at underlying disease processes and potentially response to treatments.
Great, thank you.
Chris, do you want me to take the next couple of questions?
Yes, please do. Yeah,
we can help each other out. So, I'll answer this. Is MSA an immune-supposed condition? We don't have evidence for that, but at the same time, we don't actually know what triggers the MSA in the first place. But there is no strong evidence to suggest that right now. I hope everyone agrees with me. The next question is quite easy to answer. Are we trying to find a way to identify earlier MSA so that we can treat, so that treatment is found that slows progression and they can be treated earlier? Yes, the goal is to be able to diagnose as early as possible and to intervene to at least halt the disease at that stage. Ultimately, we will want to get rid of whatever it's causing the condition, but I think if we achieve to diagnose early and stabilize the condition at that point, I think we are winning. And a lot of the trials right now are looking placebo-controlled for randomized placebo-controlled trials are looking specifically at that, at what's the difference between the patients who take the drug versus the patients who take the placebo, and looking what is the progression in the two groups. So yeah, an earlier diagnosis hopefully stops the disease earlier in its process. are all the research trials advertised on the MSA Trust? I think so. Has anyone approached the manufacturers of PBM? I don't know. Chris, do you know what that is?
No, I'm not aware of that. I think this would be something that maybe individual researchers might look into on a kind of individual basis, but I'm not aware that the trust has a position on that. But in terms of the research trial, we certainly try and make sure that the trust website is up to date with information for people about what's going on, both in terms of research studies and clinical trials, for sure.
I'm going to start soon with using infrared in Parkinson's, though. So that is, we will see if it works. Is photomodulation, and we are interested in the motor fluctuations. So, but at the moment we are just the plan is to do in Parkinson's.
And maybe, Professor Hogarth, you could answer the next one if it's useful to have regular PET scan, say 1 or 2 years.
No, depends what kind of the FDG could help in the diagnosis if were well standardized, but I wouldn't really use to assess the progression. It might be useful to check, and this has been done in Parkinson's, to check the result, the effect of some medications. But again, it's something that is not fully standardized, so more research is needed. But there are clinical trials that have started looking at changes in glucose metabolic networks in the brain.
So I think that's the same as our practice here at UCL. We use it for diagnosis, and once we have a diagnosis, we don't really repeat. But I think with PET scans, they're different PET scans. Each of them is measuring different things. There is a lot of work into PET scans trying to measure, for example, synuclein or other markers like that. So once we have a marker that is more specific to MSA, then we probably will change our answer. But for now, the markers that PET scans are measuring are probably not enough evidence to say that repeating it once we have a diagnosis, that repeating it will help. So that's just our clinical practice, but yeah.
It's the same for us as well. It's a diagnostic tool.
Okay, so I think this is the last, probably the last question we'll take in the interest of time. So if everybody who's given talks or intervened today could give an opinion, how does all that imaging, early detection of MSA link with finding a cure for MSA?
Well, the first thing is that if we find some specific markers, we might understand better what the mechanisms and see what are the early changes. So that could somehow help us to understand what are the targets for a treatment. For example, if we see that we find a specific marker and there is a specific pattern for inflammation, we might say, okay, macroinflammation is a target for medications. The other thing is, as it was mentioned before, having we don't have a realistic marker of disease progression. So sometimes these are diseases that luckily are very slow. So sometimes we need to do these clinical trials for years and years before we can see if there are actually a result on slowing down the progression of the disease. If we have something that is realistic, as Viorica was saying before, that we can measure in a short term, in 1 year, for example, and we know that the medication is able to modify that progression, that could help the development, because many companies that at the moment are not investing because there are no biomarkers, there is no reliable measure, they could be more interested in investing funding to develop more products, because they have something that they can measure the effect of the treatment against. For example, if you have high blood pressure and you want a drug, you want to develop a drug for blood pressure, it's easy because you check the blood pressure before, and then you give the medication, and then you measure the blood pressure after, and you can see there is a drop, so you know the medication works. We need something like that in MSA and in Parkinson's, something that is realistically we can rely on and is valid in the short term. So that will help more companies to invest in this field.
Absolutely. And the other thing to say is, if you have something that changes relatively quickly, just simple things in terms of, like, getting proof that your drug is getting into the brain and is doing something really helps the early stages of drug development. So there are lots of different things that without biomarkers, it's very difficult to go down this process of developing new treatments.
Well, that's great. So those are great closing remarks, and I think summed up the session really well. So I'd just like to. I think we'll close the session now, and I'd just like to thank our speakers, Professor Pavesi and Professor Hoggard, for excellent talks. Thanks to everyone for the questions and engagement with the session. I hope it was interesting for you, and please do feel free to give some feedback to the organisers. I'd like to thank Dr. Chelburn, my co-host of the session, and thanks to the